us today for how to improve glucose control in your diabetic patients using remote patient monitoring. My name is Sunny Gia, and I'm on HealthSnap's business development team. We're so excited to have you join us today. And with November being American Diabetes Awareness Month, we wanted to highlight that today approximately 1 in 10 Americans are affected by diabetes, with 90 to 95% of those cases attributed to type 2 diabetes. It was historically referred to as adult onset diabetes, but a growing number of children, teens, and young adults are now affected by this chronic and often lifestyle related condition. While patients have various disease management options, remote monitoring of glucose indicators and their various lifestyle determinants, all overseen by a clinical care team, is a logical solution for ongoing condition management and even improvement. So what will we be discussing today? First, the relationship between glucose, insulin, and a healthy pancreas. Second, the role lifestyle and behavior play in managing diabetes. And third, why remote monitoring is so effective for ongoing disease management. Also, we encourage you to please submit your questions as they come up during the presentation. We'll be sending some time on Q&A toward the end, and you'll see there's a Q&A button toward the bottom of your screen where you can feel free to submit your questions at any time. And with that, I'm so excited to introduce you to HealthSnap's Director of Product Science, Craig Flanagan.
Thank you very much, Sunny. And we are well into now National Diabetes Month. And in the spirit of awareness, we thought it would be appropriate to provide an introduction, or for many of you, a reminder of the importance of monitoring patients for their glucose control, and also beyond the glucometrics and into those underlying lifestyle contributors and modulators of that glucose control. And while you may know HealthSnap as a company that specializes in patient monitoring, we are at our core about enabling physicians to make the most informed decisions by providing meaningful information. And when it comes to chronic cardiometabolic diseases such as type 2 diabetes, this must include how we move, how we eat, how we're stressing and sleeping. And as somebody said, well, about 1 in 10 of us are now considered diabetic. And that's already putting a stress on our healthcare system and contributing greatly to the astronomical cost of care in the United States. We really need to pay attention to the 88 million Americans that are sitting like a tsunami offshore, ready to kind of drown our healthcare system. And without a concerted effort that is lifestyle focused, they likely will. So the big question is, if we put it in 2020 terms, how do we flatten the curve? After all, prior to COVID-19, this impending onslaught of type 2 diabetes, already it's the leading cause of adult blindness and amputations. It was already a leading public health threat. And now there's evidence to suggest that COVID-19 has accelerated this problem. And it's a huge threat because type 2 diabetes and prediabetes are part of an interrelated cluster of diseases that share common origins. It's not isolated. Poor glucose control reveals that we're at an elevated risk for other diseases like heart disease, Alzheimer's, and vascular dementia. And we're more likely to suffer from severe depression and the most common forms of cancer. And this has been coined the disease some of physical inactivity, since these conditions arise as a product of sedentary behavior and the subsequent abdominal fat storage and inflammation, and of course, insulin resistance that comes from it. So let's take a first look here at the basics of blood glucose control. Now, glucose is our brain's primary fuel source, but we have to maintain around 4 grams of it in our blood at all times. Not too high, not too low, keeping around that 4-gram mark. And these little orange dots here represent glucose. And in response to elevated blood glucose, say after a meal, insulin, an anabolic hormone produced by your pancreas, it binds to receptor sites on the cells, which trigger these GLUT4 transporters from within the cell to then translocate up to the cell membrane and then grab glucose and drawing it into the cell so that it could be used as fuel or stored. And in type 1 diabetes, and this is considered to be an autoimmune disease in which the insulin producing beta cells of the pancreas are destroyed, causing the type 1 diabetic to rely on exogenous forms of insulin. But it's difficult to keep blood glucose levels in a healthy range for this population. And unfortunately, this form of diabetes is becoming more and more prevalent, with now 1 in 300 kids being diagnosed with the disease by age 18. Monitoring for this population is extremely important, but it's more about keeping a close eye on the data surrounding those blood glucose levels themselves. But for today, let's examine a much more prevalent case, and that's impaired glucose tolerance. And these are patients with blood glucose levels below the thresholds that classify them as having type 2 diabetes. But these underlying pathologies of prediabetes are very troubling, and they extend into the aforementioned cluster of diseases, which include heart disease and cancer, are two major causes of death in our country. And here, our cells are just not as responsive to insulin as they should be. And the pancreas replies, in some of the insulin is still working, of course, in this state, but the pancreas replies by saying, well, that amount, that dose of insulin didn't work. I'll just make more. And this higher dose often does do the trick to keep your blood glucose in check, but at least for some time, and then it may continue to rise. Now, a major cause of this insulin resistance, as we said, is inactivity, and that's for several reasons, including the fact that a muscle who didn't just deplete its glucose stores with exercise simply doesn't need to request more glucose. Also, the fact that we can inappropriately store fat in the muscle, that can disrupt the insulin signaling pathways. And then inactivity reduces the number of those GLUT4 transporters, those stars there on the graphic. And that reduces our capacity then to extract glucose from the blood, and further leading to that elevated blood sugar. And here is type 2 diabetes, where all of those years of effort by the pancreas to overcompensate for the cell's resistance to insulin has worn down its ability to properly produce insulin. It was just too much of a burden over a long period of time. And while there may be some insulin that's doing its job there, there's just not enough to handle the barrage of blood glucose. And patients end up with sustained high blood glucose levels. And this chart here puts those processes in, I think, a very nice perspective. A metabolically healthy individual, if I bring my cursor up here, a metabolically healthy individual is able to maintain appropriate glucose levels with very little insulin. But for the same reasons why I'm currently on my fourth cup of coffee this morning, as cells become desensitized or resistant to insulin, more is required to achieve that same desired effect. But look what happens. Those poor beta cells of the pancreas that make up just 2 grams of your entire body, they reach a point where they just can't do it anymore. And that's when we see a more rapid rise in this blood glucose over time into those areas that we classify as type 2 diabetes. And notice that the insulin production here is down. It's lowered. Your pancreas just lacks the capacity to produce insulin so much. And so a late stage type 2 diabetic may resemble a type 1 diabetic in that they may become dependent upon that exogenous insulin. So the question then turns to monitoring. And if we know these are the relationships that we really need to keep tabs on, what are our options? And there are several tools in the sort of an investigative toolbox here. And obviously, looking at blood glucose alone can be a bit deceiving. If we're only looking at the glucose, then we may miss a good chunk of this initial disease progression. Now, we can estimate the average long-term status of this blue line by with hemoglobin A1C, a marker of long-term glucose control. And with newer tools such as continuous glucose monitoring, we can get a lot more clarity into the daily fluctuations in glucose and how often we're in range, in a healthy range, and how many times per day, and to what degree that we're falling out of that range into a hyper or hypoglycemic event. But what about this yellow line? Okay, what about the insulin? What about the burden on the pancreas? we can look at serum insulin levels, and we can also search for how much C peptide that we have in the blood. And when we produce insulin, it's in the form of this inactive proinsulin. And then that gets split into an active form of insulin and then C peptide. And it just so happens that C peptide is more stable with a longer half life. So it's a great indicator of insulin production, or in other words, how much work the pancreas is actually doing. How about measuring your insulin sensitivity? Well, if we know the value of the blue line, and we also know the value of the yellow line, if we know our insulin, we know our insulin, we know our glucose, then theoretically we should be able to estimate the value of the red line here, the insulin resistance. And that's exactly how computed variables like HOMA-IR tend to work, and they provide a great progress report along a plan of care. And we could sum those all up into three major options for monitoring glucose control using a glucometer, for monitoring measures, snapshots of the day to identify trends in maybe the fasted state with morning measures, or a post-meal to be informed about how the body is processing its food. And the blood test is, of course, necessary for digging into those insulin glucose relationships. But take a look at the continuous glucose monitor here. This is really the way of the future, and in that it's more informative and it's less cumbersome. And as we can anticipate advancements in this technology over time that will make it more ubiquitous for our patients. And it's primarily used in patients right now who are insulin dependent, such as a type 1 or those late stage type 2 diabetics as well. But these CGMs are, I think, really cool, and they allow clinicians to use these innovative metrics that are great for setting goals within a care plan, such as the amount of time that a patient spends within a target range. Okay, when trying to maximize that over time and minimize, especially this time down in hypoglycemia and also in hyperglycemia as well. And they also can show the time of day that patients are most susceptible to experiencing these high and low levels. And again, more information means more informed decision making. And despite their lofty cost, at least in the type 1 diabetes population, the use of these has been shown to prevent future healthcare admissions and future healthcare costs within that patient population, and maximize quality of life as well. So there's a lot of promise with these CGMs. But we're exercise physiologists here at HealthSnap. And so as we look at the influence of lifestyle, let's see what's going on during exercise itself. And here, the contracting muscle, skeletal muscle, stimulates glucose uptake. It's saying we're running low on fuel, we need more. And notably, insulin here is not required. So if you're exercising for, say, 30 minutes a day, you're already giving that pancreas a break. So that's important in exercise itself, but even more so, what about the after effects of exercise? So physical activity has been shown to improve insulin sensitivity, lasting from 48 to 72 hours after exercise. And this allows the diabetic to function more normally, okay, as glucose levels are temporarily lowered, and then the demand for insulin is reduced, sparing the pancreas yet again. And this occurs after mild and moderate cardiovascular exercise, resistance training too. And the longer or more intense that the exercise is, the longer the insulin sensitivity enhancement after exercise. And this improvement in insulin sensitivity really is the primary reason why we should be exercising. People ask, why should we exercise? I say, to improve insulin sensitivity. It's the number one reason why we should be doing it. And look at what happens with chronic exercise. When we layer these adaptations, we improve every step of the insulin, every step of that insulin signaling pathway. And we're boosting those GLUT4 transporters and improving the oxidative machinery inside the cell, improving all those mitochondria inside the cell so that we can become more efficient at turning our fuel into energy. And this process, it's like going from needing 3 cups of coffee in the morning to 1 cup of coffee in the morning. And you're prolonging the life of your pancreas, just like you would be prolonging the life of your coffee maker. You can think about it that way. So now let's think about our muscle in its role outside of just moving our bones. People say, what does a muscle do? And they immediately go, it contracts. Well, what else does it do? From a metabolic perspective, it's the site in which we expend the most amount of energy oxidizing our fat and our glucose. And it's also where we store a lot of glucose in the form of glycogen. So we should think about our muscles as these reservoirs or sinks for energy from the blood. And the more muscle we have, the greater the opportunity to clear excess glucose and fat from the blood. Now, this is particularly important for older populations who are losing muscle mass over time. That atrophy of aging reduces the destination for these blood-based fuels. And it's therefore important to monitor changes in body composition, in lean mass and muscle mass, where reductions in lean mass over time can predispose patients to poor blood glucose control. And this also points to the necessity for muscle building exercises via resistance training to maximize these fuel reservoirs. Now, the American Diabetes Association says to try to exercise every single day, but at least make a point to not go 2 or more consecutive days without exercise. So let's look at why they would say such a thing. And after an exercise bout, we have that residual improvement in insulin sensitivity that we talked about before, and shown in green on this slide. And due to factors such as an upregulation of those glucose transporters and other factors that point to this inherent desire for the muscle to refill its glycogen stores after depleting them with exercise, that improved insulin sensitivity, though, it dissipates over time. It dissipates over the course of, say, 2 to 3 days. And then it makes sense to conceptualize this necessity for regular exercise. It makes sense to view these gaps, all right, these gaps in between session. If they're too long, we view these gaps as missed opportunities to experience those post-exercise benefits. On the other hand, when we stack these residual exercise benefits upon each other, that additive effect is stimulating these adaptations that will improve that baseline insulin sensitivity. So we commonly get the question, what is the best type of exercise for the type 2 diabetic? Well, it's a combination of aerobic exercise and resistance training. And that has been proven time and time again to be the most effective set of modalities than one individually. Now, lower intensities for prolonged periods of time, that works, and as do higher intensities for shorter period of times. High intensity interval training, if the patient is capable of doing that, is appropriate. And but the key overall is to stimulate the most amount of muscle mass. And once again, resistance training to build muscle is important for building up those fuel reservoirs. And while the aerobic training is important for depleting those glycogen stores and stimulating those insulin signaling adaptations. Now, those were just the muscle-centric reasons to exercise. And as exercise physiologists, we stereotypically just end up being muscle-centric at times. But what about all of these other organs associated with glucose control? Well, they all have improvements in function in response to exercise. The pancreas becomes more efficient at producing insulin, and we see a suppression in the hormone glucagon, which decreases the glucose output by the liver. So now you have a lowered rate of appearance of blood glucose. Now, exercise also reduces the systemic inflammation derived by our fat cells. And the systemic inflammation is known to impair not only insulin sensitivity, but it contributes to most other chronic comorbidities that the patient may have. And because of our exercise, we're improving our fat burning capacity, and that reduces the likelihood that fat is stored in inappropriate areas, or what we call ectopically, areas that we don't want to store fat, like storing fat in the pancreas, where it can interfere with those beta cells and insulin production. storing fat in the liver, think non-alcoholic fatty liver disease, um, and storing fat in the muscle itself, where the fat could be inappropriately stored and interfere with muscle insulin sensitivity. When we think about exercise, we're really taking the burden off of all these organ systems to allow for improved glucose control. So, yet again, another reason to exercise. But exercise isn't the only remedy. Now, here's a diagram from a great paper on the cardiometabolic effect of intermittent fasting. And notice that these responses are extremely similar to that of exercise. If you go item by item, you're going to see a ton of similarities. And now there's a reason for that. The reason is they share a common denominator. They stress our cells by putting them in this lower energy state. And that lower energy state initiates these cell protective processes. We increase autophagy, which is like taking out the garbage inside the cell. And we become more resilient to stress, in part by building up antioxidants inside the cell as well. And we add more mitochondria so that we're better prepared next time to consume more fat and more carbohydrates to be able to restore our energy levels. Why? Because we're in a lower energy state. So all of that should make sense. Of course, if you spend too much time on this side, that could be detrimental. You can over exercise, you can over fast. It's called starvation, right? And we do have to eat. And when we do, we get these anabolic benefits that we need for cell growth and energy storage. And unfortunately, in our culture, we spend a little bit too much time, or a lot too much time, on this side of our slide. And just think about it. If we are sedentary and we have consistent access to an abundance of food, especially processed food, we may never venture into the low energy mode. And we may not get these types of benefits within the cell, at least not enough to avoid chronic disease and enhance lifespan. So a lot of evidence is now showing benefits of switching back and forth between the two sides of the slide, the surplus over here, the energy surplus and energy deprivation, from low insulin over here to higher insulin levels over here, from being more glucose dependent over here to being more lipid and ketone dependent over here, and what's called the so-called metabolic switch, going back and forth. And when we understand the baseline mechanisms, we realize that there are many potential solutions for improving insulin sensitivity. And that gives our patients a lot of options. So some of your more social patients may take well to, say, a group exercise program, and some may prefer a fasting regimen. Others prefer, say, a ketogenic diet that seeks to maintain low insulin levels without the fast. And some people do very well with more incremental approaches, such as avoiding, say, nighttime calories and choosing and pairing foods to lower the glycemic load and subsequent post-meal insulin response. And of course, having your patients avoid drinking their calories and sugary sweetened beverages. That should be always it's the lowest hanging fruit. It's the first line of defense, since that really keeps us on the left side of this slide. Okay. So while there are several approaches to offer patients from a dietary and exercise perspective in terms of intervention, the key is to effectively be able to monitor them and have them monitor themselves. And that's why we designed HealthSnap to serve as a lifestyle monitoring tool that helps clinicians, that enables these clinicians and their care teams to keep track of not only those glucometrics, we have those, but also the lifestyle changes that influence them. And when a patient's blood results come back showing they're in a pre-diabetic range, the first thing clinicians do is talk about lifestyle, and they should. But maintaining accountability through ongoing communication outside of the doctor's office is the only way that most patients will end up sticking to those seemingly generic recommendations for diet and exercise. So here's a view of a patient's outcomes within the provider portal, and where Just say when there are changes in your patient status, you can be alerted with any of these. You can always customize the thresholds at which you like to be alerted. And then on the patient facing side, we take our role of patient education very seriously. We want to communicate some of these factors and the reasons why they should be eating in certain ways and exercising in certain ways, so that they're better informed as well. And so we've developed our native app as a way for patients to view, track their status, and sift through lots of content that's designed to be actionable and facilitate behavior change at the patient level. Now, we'd be remiss if we didn't mention stress and sleep here. And I know Sunny always asks me about stress and sleep. So I want to finish talking with that. And the major stress hormone, and I should have included this in the other slides, but I didn't. The major stress hormone for chronic stress is cortisol. And cortisol is a glucocorticoid. It increases blood glucose production. And it also eats away at your lean mass as well. It actually tells the protein to actually turn into glucose at the site of the liver. So an overexpression of that cortisol can lead to too much blood glucose. Too much stress can lead to too much blood glucose. In fact, an overexpression in a clinical state could cause a certain form of diabetes as well, adrenal diabetes. So stress management techniques can be very helpful, especially those who need it most. And on the other side, sleep is another component that I think we're learning to appreciate sleep more and more. We now know that there's a U-shaped curve with sleep and metabolic disease. Too little or too much sleep is known to increase our risk of things like diabetes and heart disease. But even more importantly are these patterns of sleep. The patterns of sleep appear to matter a lot. Now, I don't know if our audience has ever heard of social jet lag or not, but it's a shift in the sleep midpoint from work days to free days. So staying up later and sleeping in on your weekends. And as benign as that seems, and we often say we're just catching up on sleep, it's actually very detrimental to your insulin sensitivity. And those that are accustomed to a 2-hour forward shift in that sleep midpoint, the sleep midpoint's the time at the middle of your night's sleep. You think about that. If you have a 2-hour shift or more, you actually are doubling, if you're doing this regularly, you're doubling your risk of developing impaired glucose tolerance and type 2 diabetes. So yeah, we should be taking that very seriously. And the question is always why. And part of that fact is that we're often up late eating and stimulating this insulin response at certain times of the day that our body is woefully prepared to handle it. And the other part is throwing off circadian rhythms that have to deal with insulin production and sensitivity. Keep in mind that our cells have these clock genes that respond to the perceived time of day. And if the pancreas is acting like it's 3 p.m. and the muscle is acting like it's 6:30, well, that mismatch can create an issue then with that insulin sensitivity. So that is what we have for that. Sunny, did you have any questions? We had any questions from the crowd in here?
Thank you so much, Craig. So we promised about 30 minutes today. So thank you everybody for staying with us. But and thank you, Craig. I know that we do always talk about the importance of diet and exercise, which are really important, but also the benefits of stress and sleep management are highlighted here as well. So thank you there. But feel free to reach